Hi everyone, welcome to the presentation on least restraint at the Mount Continuing Care Community 2021 edition. Introduction. The mission at the Mount Continuing Care Community is to provide each resident with the highest quality of living in an environment that upholds the emotional, physical, social, and spiritual well-being of all residents. In order to ensure resident and staff safety at the Mount and to achieve quality client care, least restraint may be used in combination with person-centered care. In this module, we will review the policy and procedures around least restraint. Learning objectives. By the end of this presentation, you will understand the revised least restraint policy and be able to discuss it with your peers, the risks of initiating least restraint, the decision-making process associated with least restraint prevention and initiation through the use of the decision tree, interventions to be initiated to prevent an episode of restraint, the importance of documentation when assessing the client with the option to prevent or initiate an episode of least restraint, and lastly, long-term care specific guidelines regarding least restraint. First off, let's start with a myths and beliefs quiz. To yourself, reflect upon these questions. A. Restraints prevent injury. True or false? Properly applied restraints will not harm clients. True or false? Clients do not mind being restrained, especially if they are confused. Clients will decrease resistant behavior, for example, agitation, if restraints are used. Restraints are appropriate when clients cannot be closely monitored. Is it true or false that F, practical alternatives to restraints do not exist? G, medication is a good alternative to physical restraints. Clients cannot refuse restraints. True or false? Restraints save time. Is that true or false? And lastly, do you think it is true that restraint reduction efforts are costly? In fact, all of the questions are false. So why do healthcare providers initiate restraints? The most common reasons include danger of falling and psychomotor unrest in the resident or client, interference with use of therapeutic devices or interventions, and that healthcare provider protection from physical abusiveness or combativeness. When should restraints be used? Client restraints are used to prevent serious bodily harm to the person or to others. Different types of restraints. There are three main types of restraints. Firstly, environmental or seclusion restraints. These include barrier or devices that limit the locomotion of an individual and thereby confines them to a specific geographic area of location. An example of this is a secured unit. A second type of restraint is physical or mechanical. These include techniques or devices that manually prevents, restricts, or subdue the free movement of a client. For example, the use of a manual hold or a wheelchair belt. Chemical restraints are pharmaceuticals administered for the sole purpose of temporary behavior management or control. Examples of these include benzodiazepines or antipsychotics. Now let's look at the least restraint decision tree. The decision tree details the least restraint decision-making process. Firstly, we should assess and describe the client's behavior. Remember, All human behavior have meaning. So what is the etiology or cause of the behavior? Think about the medical, physical, and psychological factors that might be contributing to such behaviors. For example, could they have a UTI or perhaps an electrolyte imbalance? It is important to explore interventions and alternatives that could potentially treat the etiology first. For example, it may be helpful to offer fluids, practice routine positioning, and deliver pain relief. If interventions are unsuccessful, consult with your healthcare team members, the resident, family, and substitute decision maker. Ensure documentation between the resident and family and staff is well documented. Next is monitoring care. Any member of the care team can release or remove a restraint during care delivery. Toileting should be practiced every 2 to 4 hours depending on the resident. It is important to check clients every 15 minutes for the first hour until client behavior is stable, and then every 30 to 60 minutes until the restraint is discontinued or is no longer needed. And remember to document according to protocol. When it is time to discontinue the restraint, the decision should be reviewed by healthcare team members when the client no longer meets restraint use criteria. Remember to document the removal of the restraint and that an order is not required to discontinue a physical restraint. The decision. Decisions regarding the use of physical, chemical, or environmental restraints must involve the client, substitute decision maker, and healthcare team members. Capable clients and their substitute decision makers have the right to personal risk and to refuse a restraint when it does not involve serious harm to self or others. Documentation of restraint use. The use of any restraint is to be fully documented in the client's record and care plan. The documentation must include the use of the decision tree when determining which level of least restraint, the use of the decision tree of least restraint, the description of client behavior, the client assessment, their etiology or cause of the behavior, and steps that were taken to correct the root cause. Remember to document interventions or alternatives, as well as de-escalation tips that were used. Document the client and family or substitute decision maker involvement in decision making. All discussions and conversations with healthcare team members and their involvement. Document when the family or substitute decision maker have been informed of the decision to use least restraint for the safety of the resident, as well as fellow staff and other residents. The type of restraint used, as well as the date and time of application, any reassessment and monitoring, a detailed skin assessment, especially when physical restraints are used, document when the least restraint is discontinued. Remember to include by whom, the date, as well as the time. And lastly, remember to document the client's response and the outcome of the least restraint use. Documentation of the communication with the family or substitute decision maker. When communicating and documenting the communication with family and or substitute decision maker, it is important to include the risks if the restraint is not initiated, such as potential harm to the client themselves and or other clients, family members, or the healthcare provider. Physical risks of restraint, such as asphyxiation, aspiration, abrasions other skin injuries, impeded circulation, and decreased mobility. Also, you must discuss the psychological risks of restraint, such as the basic need for freedom is denied, loss of self-esteem and dignity, overprotectiveness can rob a person of the excitement regarding life, consistent use of restraint can lead to dependence on its use, as well as fear of being abandoned. In emergent situations, initiate the approved restraint for the purpose of providing safety for resident, staff, and/or others. Use de-escalation strategies, and remember to inform the nurse practitioner or physician as soon as possible after restraint initiation if they aren't aware. Chemical restraints. To implement a chemical restraint, you would need an order from a physician or an MP. Start with the lowest possible dose. The oral route is the preferred route of administration in non-emergent situations, and intramuscular is preferred in emergent situations. The RN must request medication reassessment at a minimum of every 3 months and when the resident's behavior is stable. Least restraint in long-term care. Remember, restraints are always temporary and considered an unusual measure. A restraint is not a treatment, but an intervention. Restraints are to be used only as a last resort and for the shortest time possible. In emergency situations, initiate approved restraint. Non-manufactured restraints are not approved, for example, towels or clings. And remember to always document. For many residents who are deemed incapable of deciding for oneself, thorough discussion with the family is required. During this discussion, the resident's behavior must be included, the decision-making tree should be used, as well as interventions and de-escalation tips should also be discussed. Documentation of that conversation is in place of consent, so it is very important to include in the resident's records. Also, just to note, the standard for private long-term care is that medications are reviewed at least every 6 months. If you have any other questions, feel free to reach out to the management team at the Mount Continuing Care community. Thank you.